We're going to go ahead and get started with the second session, and people will continue to trickle in, but for the benefit of a lot of the people that are on the phone today, we'll get going. This is our second session called Present at a Distance, Capturing Value in Remote Patient Monitoring. I was delighted to hear remote patient monitoring mentioned already in our first session. It shows a bit the prevalence of it in the market and how much it's transforming the patient landscape. So thank you for joining us. I'm extra excited about our three panelists. Much like our other panels, we tried to find experts in this space who had a wide diversity of perspectives, so coming from different types of companies for the benefit of our audience. So I'll introduce you to them, and then we'll do a bunch of questions, and we've allotted a fair amount of time at the end for questions from the audience. So feel free to jot down questions, and again, for those listening on the phone, you can also submit questions as well. So I'll start first with Greg Anthony, who is the Associate Administrator at Mayo Clinic's Center for Connected Care. The Center for Connected Care is focused on the development, design, implementation, and ongoing monitoring of a wide variety of digital health tools. And they have comprehensive responsibility for asynchronous and synchronous and remote patient monitoring platforms for all of Mayo. And that's for both the web and mobile platforms, so an enormous amount of responsibility. Mayo Clinic itself, as many of you know, has been an early leader in the digital health space with a wide variety of connected care solutions, including the Mayo Clinic App, which is an award-winning app for patients and consumers. Aside from Greg's current leadership role, he's held a wide variety of other leadership positions at Mayo during his 30-year tenure there. So welcome to Greg.
Thank you.
Harsh Darwad, sitting next over, is Chief Technology Officer at Nihon Kohden, which produces remote patient monitoring devices, along with many other products and services. In his role as CTO, Harsh provides strategic leadership and direction for the remote patient monitoring related software. And that includes the patient data acquisition systems and management, which helps reduce costs and improve care for their customers. Prior to Nihon Kohden, Harsh was Director of Software Development at Pfizer. And that's where he oversaw the development of infusion pump technology and value-added software applications. And he also oversaw an initiative focused on innovation and pipeline development. He worked previously at Hospira, and he was general manager for leading an R&D site. And he's also worked at Siemens and Philips as well. So he has a really broad perspective. Thank you for joining us, Harsh. Megan Delorier, further to the left, is a partner here at Dorsey. She practices in complex business litigation, and she has a specialty in healthcare litigation. She is co-chair of our healthcare litigation group. In addition to representing clients in a broad array of general business lawsuits, she specializes, as I mentioned, in healthcare litigation, and especially exposure and liability-related questions. She works with and represents healthcare systems, providers, insurance companies, telemedicine entities, certification bodies, and professional medical associations, amongst others. She also works with different international legal issues. Particularly relevant for today, Megan has advised clients of all types on digital health-related issues, particularly remote patient monitoring, and especially with liability-related questions. She's actually one of my go-to attorneys for this issue, so really glad she could join us. So thank you all. It's wonderful to have the provider, the manufacturer, and the attorney weighing in on remote patient monitoring systems. And we'll jump right into the questions. So first off, thought we would start right with the title where we talk about capturing value. And one of the issues that the three of us talked about is that really a key aspect of value is in how remote patient monitoring can transform care for the patients and the patient journey. Can you tell me a little bit about what the impact to the patient has been at your organization, Greg?
Yeah, I think the technologies that are surfacing at this point and even in the recent past here really enable us to move beyond these points in time where we access healthcare. We try to diagnose and treat based off a point in time of data and information to now where we can actually stream and have data coming in over a longer period of time and intervene more quickly with patients as a whole. You know, I'll just take a case in point from this last week, and that was a situation in terms of a patient that had some arrhythmia issues and had actually contacted their physician. Their heart rate had dropped to 30. They picked up on it on a remote device that they had, talked with the physician, and it was an agreement, send the image, the recordings on through. They were able to actually diagnose right from those recordings the patient had at their fingertips. In the past, what would have occurred was, okay, let's get you scheduled for an appointment. So if you're lucky, within the next week, you would have been seen for an appointment. If not, you would have gone to the emergency room. We probably would have set you up for a Holter monitor. So that would have been a 24-hour reading. You would have been set up with it and then dropped the device off. Another day or so for getting interpretations and then follow up with physicians. All of this occurred within the matter of just about an hour's amount of time in terms of being able to get to the heart of a problem and being able to really help that patient. So I think one of the key things is that ability to get more data in a more timely fashion, to be able to intervene more quickly and improve overall outcomes. And over time, that actually helps to reduce the overall cost of care.
Dramatically reducing the timeline there.
Correct.
What about Harsh from the device manufacturer's perspective?
Yeah, so as from a manufacturer standpoint, our role is to help provide the infrastructure to enable what Greg was talking about. And we've seen a big change in the market. We see a lot of hospitals asking for technology to enable them to monitor patients, one, from a different physical location than they're located at, and two, to have access to the continuous stream of data that you talked about. And it solves for multiple purposes. One, sometimes to retrieve live information so that they can have somebody at a remote site monitor these patients and how they're doing, as well as have that data continue to flow into the patient charts, so that that data can be accessed from anywhere within that hospital group by the physicians, because they all generally have some kind of EMR and they can log in and see how their patients are doing, so that not only they can access it, the information in their patient charts, but also potentially have access to live streaming information so that they can actually look at how the waveforms are doing or how their vitals are doing in a live session. So those requests are increasing. We see a lot more of them than we used to in the past. And I think the trend's only going in that direction because, one, I think it provides, it's a case for technology providing potentially better patient care as well as cost benefits to the hospitals. So it's something that's only going to increase, and I think it's going to get more and more advanced as we go forward.
Wow. Megan?
Sure. From the liability side, on the one hand, it's absolutely true. This is going to improve patient outcomes. Patient care will get better. And as a result, in theory, liability should go down. And that's the hope and expectation. In the meantime, however, all the things that make remote patient monitoring great is essentially the information. That can also be a detriment to the physicians in that they have information overload. They have so much data, they don't know what's significant, what's not anymore. So it's really critical as more and more people are, creating patient-generated data that's getting provided to the physician or caretaker, that there are adequate systems of alerts and analysis in place so that when intervention is required, it's clear and everybody understands what that looks like and how that's going to happen. Because otherwise, there would be concerns that there's all this data sitting out there. There are times where a physician in a normal face-to-face interaction would have intervened or done something, and that data is just sitting out there. And if there is an adverse event and I'm talking to a jury is not going to be sympathetic to the fact that the doctor had this information and didn't act. It's going to be a transition to make sure everybody understands what's happening with the information and how alerts are going to be set up is really key.
Wow. Do you think that actually... Oh, go ahead.
No, just to add to that point, I think as the technology continues to evolve and as we do more and more of things remotely, I think as manufacturers, we have to work very closely with the clinicians and doctors to figure out. You're absolutely correct. There is information overload today. We used to have, medical devices used to do one thing previously, a decade ago. They used to do one thing, and that was their primary function. Then they all became smart medical devices, which basically meant they could talk to one another. You could tell them something, and they would tell you something. And then it got to where they would all start sending this massive amounts of information that's available for use. And we know that the amount of information that we generate, as an example, so we make various kinds of physiological monitoring systems. Only about 10% of that is ever looked at, even today. So we generate so much that it's not possible for human beings to take it all in and make decisions. So I think the next step in this in digital health has to be where how do you take all this information and provide actual actionable information that is relevant for the patient and the clinicians. So I think that's something that has to happen, and it can only occur with close collaborations with the manufacturers and the hospitals.
I think what I would add on here, and an approach that we've taken with how we look at digital products, whether it be remote monitoring or other types of products, is it's very easy to all of a sudden be inundated with a million different types of technologies that people are bringing together. And really, we step back and take a look at how do we standardize, how do we systematize the workflows, the process, how does it get integrated in to the work that needs to be done. And then ensuring that we've got products that are actually scalable. What's scalable in a small community-based practice may be different than what's scalable in a very large organization. But those are kind of three basic principles that we talk about in the industry in general, but that we also take a look at in-house. And it's that systematization of how does it tie into the workflow to ensure that we try to prevent these points of just data flowing in, but there's no action being done with them. And so that is pivotal versus lobbing a technology over the fence. Here's a great device, throw it over the fence, and good luck. And so that it takes a lot of effort around workflows. I'd say technology is probably one of the easier components of this. It's everything else that to dovetail it into how healthcare is delivered to make it really effective and prevent the issues down the road.
I couldn't second that more heartily, actually, because with most of the clients that we work with, people, both the buyers and the sellers, are so excited about the technology, but nobody stops to actually map out what the process will be and what the clinicians will be clicking on, how hard it will be. So couldn't agree more heartily. I think one of the themes, certainly the three of you have spoken about now, is the data, and certainly the challenge of kind of the overload. But what do you see as the opportunities for how the data could be used, whether for the patient's benefit or the organization's? Maybe Harsh?
Yeah, so I think we're at a stage in the evolution of healthcare where there's no shortage of computing power, there's no shortage of memory. It's real cheap, we can get it pretty easily now. So now what to do with this large quantities of data that's being generated and how to make it more useful. And I think this is the stage for the next decade, essentially, where how do we take all this massive amounts of information about us that is being generated, and then to use that information to figure out how can we help clinicians and doctors make better decisions. And there's lots of research going on in the industry today. A lot of different, even at Mayo, I know there's a lot of research going on in this field, and there's a lot of other research hospitals like Johns Hopkins and UCSF, et cetera, are doing a lot of different research, and this slowly, it's getting into AI, or artificial intelligence, to see how do we take this data and what do we do with it. The previous panel also talked about ownership and who owns the data, and I think there's different answers. My personal perspective and our perspective, from our company's perspective, is I think it's the patient's data, and hospitals use that data to give them better treatment plans. And our role as manufacturers is to enable how do we create value of that data in a sense that to give you the right information to the doctors. But that's the next phase. I think the digital health will be to take all this information that we're generating, and then potentially also the challenge with the data today is each of the vendors create their own data, but it's not looked at holistically. So it's very siloed. So a typical hospital has somewhere around 50,000 vendors, from what I've heard. And if that's, maybe that's a larger, medium-sized hospital, but even if if you look at smaller hospitals, that's still a large number of vendors. So now each of them are generating their own data. It's proprietary to their, whatever their protocols are, but it's all patients' data, and collectively is what it makes sense. As an example, a simple example for, say your blood pressure goes low. So typically some device would alarm in a hospital if your blood pressure goes below a certain threshold. But the context is more important. Why is it going low? Did they take any medication that would cause it to go low? Or did something else happen that would cause it to go low? Maybe it is, in some case, expected, some case it is not. That context is missing today in how healthcare is delivered to patients. And that context today, we rely on experts like physicians to make that call. And I think we can help from a technology standpoint, and the manufacturers, I think we can do a better job of providing that context to them so that then they can more quickly make those decisions.
Have you seen, as a quick follow-up to that, have you seen, whether in your current role and others, hospitals or other parties actually managing to aggregate all of that siloed data and do something with it?
They are. So some hospitals are doing it. As a good example is I think like Penn Medicine manages some of the tries to manage it, some of their data, but they haven't done it successfully yet. I don't think anybody that I know Boston Children's actually did a project with MIT and they gave up on it because it was too hard to combine all this data to make meaningful sense of it. Because it's not time synchronized in the sense that I can get data from 4 different sources, but do I really know what was happening at a certain instant of time? Because it's all stored very differently. It's all, you can't overlay one over the other and say at the same time their heart rate was here, this is what is happening to their brain as an example. It's very difficult to do, but there are hospitals trying to do it. Some of the hospitals, like Penn Medicine, I think has about 50 data scientists working for Penn Medicine. So they're certainly making the investments to go look at this and see what can be done. And I think we, as manufacturers, can do more, I feel. I think we've kind of done it in a siloed fashion today, but I think the next phase of this is to sort of look at it, get the collective data, and see what value can be added from that.
From the provider perspective, I think one of the things that we've been working on, and we've been very fortunate of our lead in the IT architecture arena, is really kind of the formulation of our UDP, our Uniform Data Platform. And that actually now has become our master file for all of the data that comes in there, regardless of different types of systems. And so that becomes the housing for it. There's still that layering on top of that of now how do you take data from all these different systems that's come together, analyze it in a way that's meaningful. So whether you're delivering care, but it can also be related to process or other types of factors that benefit the organization. So I think we've made a significant step forward. We've talked with others that have been a little bit envious in terms of what we've done, but that was really critical. That it was a strategic decision early on, and it's taken a while to build to get to that point in time. But I think it positions us now really to be able to look across devices. One of our goals has been, we want to be device agnostic, ultimately. We don't want to have to rely on any one single vendor for devices. We don't want to have to rely solely on medical grade devices. There's times and applications when a consumer grade device will work. So how do we pull in that information, but then, and now I think we've got the basic infrastructure to do it, but now how do you really analyze it and put it to use for the benefit of the patient and or workflows and processes within the organization. So I think that's a pivotal step in the pathway to where we need to go, but it's not that many are there yet.
Is the idea that the UDP is part of the electronic health record, or is it separate? And if it's separate, why?
It's completely separate. Wow. Electronic health record is only one system within the organization that needs to utilize data. Now, so our, again, master for discrete data actually sits within the UDP. Data flows through the electronic health record, but the UDP is where we can go to for our master files. And I'll take, for example, the development of Mayo Clinic App. What we've done is we've chosen at this point in time to intentionally not take the Epic patient portal out of the box because from a variety of reasons, user experience, et cetera, and our own branding of how we want to create an experience for the patient, we actually tap for any all static data, we tap the UDP for that data, not Epic. We pull that into the design of the product. Now, there are some components of transactional interactions that a patient may do. I need to update my information. So transactional pieces, we may still leverage that functionality from Epic because we don't want to rebuild that because we still have to feed back in there. But we really start to blend it together to create a unique user experience for Mayo Clinic App. And that has been more of our basic design approach as a whole. So UDP is our home that we go to and pull data from, but we do leverage transactions and other elements from other types of sources if needed.
Wow, so this might actually be your hospital example of a centralized data platform. The idea being many different remote patient monitoring devices all dump their data into this one repository.
Right.
And the opportunities being the analytics and patient care.
Is the piece that is still coming.
Certainly.
We've just completed another book of work with a vendor in terms of some of the data aggregation. So that link of now all of these different devices coming in, consumer grade devices, how do we get those all pulled in and housed there? But now it's, okay, how do we apply this and now start to run the rules engines and that. So we haven't connected all of these devices yet, but the functionality is there. We now have to strategically figure out that pathway and design how that will actually flow now. So it's a stepwise progression.
Wow. And Megan, oh, go ahead.
Sorry, just
please.
I think one of the reasons your question about why not use the electronic medical records and why create a separate one is, one of the reasons could be, and we know this, that of the data that we generate, I think we only send to EMRs about 5% of the data that our systems generate, as an example, because they don't consume all that information today, so they only want certain numerical pieces of information. So that's also could be a reason, especially if you're going to run an engine to maybe potentially detect clinical conditions, et cetera. You probably want more higher granularity of data.
Right.
I'd say that's interesting. I tend to be partial to electronic health records only because I worked at an electronic health record company, Epic. And one of the things that I hear from clients all the time is this counterbalance of you need the providers who are using their electronic health record system, whatever it is, to have one click and to see everything versus but we can do so much more in different applications. But Megan, I'm curious from all of your experiences, what have you seen as some of the opportunities with that data?
Yeah, I mean, I think it gives physicians an ability to see things, as Greg was saying, that aren't happening in front of them. So when the patient leaves, there's a wide range of information that may show patterns, that may show other physiological things happening that the physician face-to-face is not going to be able to see or gather that information. So it gives them an opportunity to diagnose things earlier, diagnose things more precisely, and just the information is valuable for that alone. On the medical records front, that makes complete sense to me because you want a medical record that the physician can use and rely on. I certainly, from a trial experience standpoint, I want a medical record that's not going to be so voluminous that nobody can understand it. I mean, you want to be able to look at it, see the key points that you need to address, see the key issues that the patient is experiencing or needs attention, and deal with those. And if you have the other 90% of that information in there, it's just going to become unusable. So it's good to have the access to it and to have it all aggregated, but to make the medical record, useful, you have to wean it down to what's important.
And I'd say that's one of the key dissatisfiers for our clinicians is that ease of workflow of interacting with the patient, going into the record, having a lot of noise there that they have to then take time to try to sift through to get to what the heart of the matter is and so they count clicks. And so you'll hear, it took me 5 clicks to get there. I want to get there in 1 click or 2 clicks. And those minor details in a busy day where you're working through a lot of patients and you're trying to analyze a lot of data are really critical to the willingness and ability to adopt into practice. And so design is essential. Again, it's more than just the technology, it's the design, how to systematize it and create it really into workflows that are meaningful and useful and have focused the information to what's most relevant.
So just to add to that, so I recently learned that Johns Hopkins has started, they have a course called Precision Medicine. It's taken by engineering students, and they give them clinical problems to go figure out from a workflow perspective and what makes sense. So they work with the School of Medicine and go figure out. And then they have a bunch of topics they pick from, and they pick a certain topic and work with the certain clinicians to figure out how to look at it and how that information can be presented in an appropriate manner that fits, rather than 5 clicks versus 1 or whatever the case could be, or it's more relevant in that place versus being available here. And I think so. This will actually, I have a firm belief that over the years, I think how engineering and medicine is taught will change regarding healthcare. I think the physicians will learn more about how to use data and how to figure out what potential value can be created from that. And I think the engineers will learn more about how healthcare workflows work, because it's the way it is taught today is very different. And I think that's one of the reasons why we have the system we have, the healthcare system we have. The engineers are just taught about, they look at it very narrowly from a data and work and what they're building and what they're trying to achieve. And I think the doctors are looking at it from a very specific patient basis. There's got to be a correlation, and I'm when I learned what Johns Hopkins is doing, I think it'll become more and more prevalent. And I think that there will be more interactions between the School of Medicine and engineering schools in the future.
So do you think that the clinicians, will need to be that much more adept at understanding data? Or
I think so. I do think so. And I think, we already see a difference. Like when we talk to younger doctors and clinicians, they're more tech savvy, so they ask very different questions to us than more experienced doctors. Now, doesn't mean that's better. I'm not saying they're the better doctors, but but I think it's going to change. I think it will change. Simple things like very simple example is everybody's got a phone now. They all know how Zoom works, on your phone. Like you scroll up, you zoom in, zoom out, and they're all touching. So we get requests from younger clinicians about, hey, why can't I just do this on your devices so that I can do the same thing that I do on my phone? And that's one simple example, but it's we get a lot of very different requests from younger clinicians than we do from experienced clinicians.
Interesting. I wonder if for remote patient monitoring companies or those looking to break into the space, I wonder if there isn't an opportunity for maybe the synthesizers or those that can visualize, bring some visualization techniques to the data so that it's easier to comprehend for anyone, whether savvy or not. Have any of you seen any of these sorts of companies?
There are products out there. I'll take the remote monitoring space for us. So at present time, we've got a particular product that's fairly commonplace in the industry in the remote monitoring space. They bring a suite of tools that are sent home to the patient. There's about 5 or 6 of them. They've got the means now with the data flowing in that actually aggregates the data and really helps to present and helps nurses that are doing the frontline monitoring to really understand and pinpoint where are the hot spots and that we need to hone in on what is within protocol, what's out of protocol, where do we focus, and that for us then triggers, it's a phone call with the patient, it's a discussion with them. And so we have those types of interactions. So there are tools out there, but I think what's challenging for a lot of very small startups, they've got the technology, the idea, but they don't necessarily have the concept of, okay, how does this work within the broader healthcare system? And that's why I think with some of these companies, that ability, which is highlighted in the previous session, to partner with healthcare organizations to be able to understand that, I think can actually benefit them in bringing product to market that is more usable because they really are working with those that are going to have to interact with the technology on a daily basis.
And lead to fewer clicks.
And lead to fewer clicks.
Yeah, so for the fewer clicks, add to the fewer clicks comment. So one of the challenges for startups, so there are startups who are trying to do all this work, but one of the challenges is if you introduce a new addition to the existing workflow, the rate of adoption is almost 0. It's you can force it, like if the head of the department at a certain hospital, if they want to do it, like follow an additional workflow, they'll force it. That department will use it. But universal rate of adoption is almost 0. So, and I think that's the biggest challenge that the startups face who are developing something like this is to how to not introduce, whether it's additional clicks or additional equipment to go log in and do something else than what they're used to. And that's the biggest challenge. And I think that's where partnering with hospitals as well as all the players who play a role in that workflow is very important. And that's one of the reasons why EMRs are very successful, because they catered it to the workflow of the hospitals. And that's a big challenge.
Shifting gears a little bit, wanted to know a little bit about the regulatory challenges, and I suspect they're very different for the three from the three perspectives. But Megan, maybe we could start with you if you could tell us maybe some of the regulatory challenges you've seen or read about.
Sure. I think one of the biggest issues in any telemedicine, but also in remote patient monitoring, is licensure and credentialing. So once you start treating patients that are in different areas, the Mayo Clinic, they're treating someone in every state. You need to make sure that you are licensed and credentialed in that state and are maintaining and complying with their unique laws. So some states you can get a specific telemedicine license. Other states you can get waived in, you can get reciprocity. If you're in a nearby state, there are certain exceptions, but every state handles it differently, which could be a really big challenge in this space. Even if you're at a small clinic in Minnesota and you only treat Minnesota patients, but you have patients that are snowbirds and spend the winter somewhere down south, and you're continuing to treat them by getting continuous information from them, maybe having a telephone call or some intervention. And in certain states, if that's widespread enough or of a certain level of frequency, you're practicing medicine in that state and you better have your license. So it's a huge challenge, I think, for organizations and providers that are touching upon multiple states, and something that there isn't anything uniform. There have been efforts to try to make it more uniform, but we're not there yet. So that is, automatically the first flag that goes up.
Be licensure.
Yeah.
You mentioned also earlier in this discussion around that juries might not be sympathetic to providers. If they had all that information, why didn't they use it, even if it actually seems unfeasible? Do you see the standard of care changing because of all of this remote patient monitoring data?
I think absolutely. I think what will happen is it will be the standard of care to use patient monitoring. And if you don't, then you're not meeting the level you need to be at. I think it's going to be a slow shift, but we're going to get to that point where if you're discharging a patient who had a surgery and you're not giving them any tools to check for infection or monitoring them after they leave the hospital, or particularly with heart issues, if you're not monitoring that after they leave, that will become the negligence standard. We're not there yet, but it's moving in that direction.
Thoughts, Greg or Harsh?
Yeah, I'd say the licensure is probably one of our key ones for the exact reasons you stated, and the amount of manual tracking that we have to do and counting interactions. So with the provider services, again, the law varies by state, and some it's a threshold of if you reach 2 or 3 in a month or a defined period of time, you now need to be licensed. And so it's a lot of effort, and I would say it's probably been one of the rate limiting factors for us in the diffusion of some of the services is state licensure. We have physicians right now that are maintaining 30-some different licenses in different states. Now with the opioid challenges and issues, every state has some form of their own opioid education. So now not only are they trying to maintain their license, they're now trying to make sure they're meeting the educational requirement that is unique to that state versus another state, because not all of those educational hours are transferable. So it's really becoming a pinch point for organizations with highly complex care that draw patients from distances. And so it is probably one of our challenges and one of the rate limiting factors for diffusion. Our view is we don't see change on the horizon. That's a legislative issue. With everything, politics gets involved. And so those political climates are always constantly working of how can we advance that. And one of the things we've talked about, even something as simple as being able to free up the follow-up of established patients. So if you've established a relationship with the patient, in your practice, that ability to at least follow up on them and when you're managing their care and not letting state lines become the barrier and that. So it's a huge challenge for us in the diffusion of services.
We've actually seen, I have to say, across a lot of clients, that this problem of licensure has been the biggest issue to be able to scale quickly. Because how do you reach so many states so quickly with all this tracking? I'm curious whether you folks or maybe others you folks have seen, are you always thinking internally we'll track and manage this, or maybe we'll partner with providers in those states? I mean, that's a build or buy decision of a different sort.
Yeah, I think what we see when we talk with colleagues, across the country, and that there's a variety of models of approach. One is, yes, you get the licensure and you manage it in-house. Alternatively, you vend out to some other type of organization or service that has staff licensed. You look at how do you tap your alumni or other networks of providers. So you have to start thinking creatively in terms of, okay, how do we meet the letter of the law, but to be able to provide services? And that becomes challenging when you're then starting to turn over the plan of care that you've developed, that you're trying to manage on and ensure those outcomes. And when you're now looking at handing that off to another organization and ensuring they've got the competency and the capabilities to appropriately manage. So those are just, it's a compounding effect, I think, on the complexities in trying to manage around the licensure issues.
Well, I think that's absolutely true. And to add to that, a bigger issue that could come out of remote patient monitoring is there is distance between the physician and the patient. And it's good because it means the patient doesn't have to come into the office as frequently, and visits can be shorter or can be farther apart in time. The downside to that is it does affect the relationship the provider has with the patient. And in terms of a potential malpractice suit, there's no question that if there's a strong relationship there, that the frequency and number of malpractice suits goes down. So we are losing a bit of that protection just by the nature of the relationship. The more and more this is occurring, and the more care is handed off to another provider or to, AI or technology.
Are there other sorts of regulatory issues you folks have encountered, Harsh, from the manufacturer perspective?
I think of different sort. So as an example, the FDA, which regulates medical devices in the industry, they're evolving with the digital health concept, and they're trying to figure out how to regulate it effectively. They're trying to figure out, there's a couple of pilot programs going on, for them to see how quickly they can look at the space and deal with, which is very different from a traditional medical device. So that's something that's ongoing. One of the challenges, it's not a regulatory challenge, but it's more of a bit of a liability challenge I do see with remote monitoring is we traditionally, when everything was self-contained in a hospital, it was either manufacturer's equipment, manufacturer's network. It was pretty clear. That's changing now with the remote monitoring. So you're now utilizing hospital infrastructure. Some of the infrastructure is built by the hospital to connect their multiple physical locations together or whatever. And so the data that's being generated by a medical device that is being transmitted over potentially, so the vendor generates the data in a sense that they're measuring the data, they're transferring it, it transfers over to the hospital's network. Then the vendor is receiving that data and displaying that information in some capacity. And now you have two different hospital as well as the vendor, both responsible or liable for certain elements of it. So when things go wrong, if it's not working, it's hard to figure out. It's not as easy to debug when it's all self-contained. Because now you have to figure out, okay, I see this, what's happening, what changed? Did the hospital change something on their network? Did they apply a new, everybody gets monthly security patches or whatever else happens, and did something break that? So it's become a little more complicated to figure out, one, just the debugging of it itself, and two, if there's any issues, who has the liability to determine whose fault it was.
So it sounds almost like the interconnectedness that you spoke of earlier that's making this data so rich is changing the cybersecurity questions that you folks and the hospitals and frankly probably all the partners are asking as far as who is connected to what and who controls what.
Yep,
Those are
exactly.
the questions. Are you folks asking those too?
Absolutely. So now we've got complex processes we work through. So any type of vendor with the IT systems, we go through what we call our SPAD review process, and it's a very detailed assessment. It gets into the security, the privacy, other technological components, and you do not go past go until you've cleared there. It's kind of like
Oh, wow.
TSA, a little bit more challenging right now. But it has slowed us down, but the same token, it has protected us. It's also forced us into ensuring that we've got a whole series of questions and things investigated and answered early in the discussions with potential vendors, as opposed to, I'm ready to go, and then the wall comes down in front of you and you can't not move forward. So that systematization of the process of being able to enable the technology has helped us. It's painful at times, but at the end, it's actually, we're better for it.
Wow. It's actually sounding more and more from the purchaser standpoint, similar to something you said earlier, the technology itself is less and less important as far as the device. I hate to say it, it sounds like. And more, how does it fit in the workflow? And can you answer these questions about where everything is flowing in a way when you're trying to decide?
I think the other piece, and this is a situation that we picked up on, but even with the vendor, and it's not knowing just what that vendor is doing, but who are their subcontractees.
Yeah.
And because of our internal systems, we actually picked up for a vendor, 3 levels deep into subcontractors, a security issue that the vendor never identified until we said, hold it, the yellow flag just went up. The vendor's like, what are you talking about? And they dig into it, and sure enough, there was a security issue 3 levels deep in subcontractors. And so you really have to keep an eye on the ball, and it's just not the ball that's in front of you, but it's the ones that are coming at you immediately behind it and tied to that first one there. So the technology is critical, important, but then it's how do you apply it.
And I think, what you're also saying is vendor selection is incredibly important.
It's huge.
We had a client, this was a couple of years ago now, but they had remote patient monitoring happening and they got in a dispute with the vendor. The vendor threatened and was starting to essentially turn off the devices and cut everybody off, which was really a big deal. They were our patients. We were in charge of making sure that they were safe and following the protocols that were in place. And we had to bring a TRO, bring it to the court and get a judge to say, you cannot turn these off. But it was a big dispute and a big problem. And when you're losing a little bit of your control that you would otherwise normally have over your patients and what's happening in the patient's ecosystem, and you're giving that control to a vendor, you want to make sure that you trust them and have the right contracts and paperwork in place if things do go wrong.
I think what's important with this as well is just because a vendor is big and a dominant player in the marketplace, you cannot assume that they are actually meeting the basic requirements. For us, and we are probably more stringent on our requirements, SOC 2 Type 2, that is a pain for any of the startups. They're not necessarily ready at that point in time. But we even had a huge national level vendor preeminent in the field, which we had to say no to because they were not SOC 2 Type 2 certified and felt that it was not important. And so we stepped away in that. So you can't make assumptions going in just because somebody is well established in the marketplace. You have to do your homework and due diligence to make sure that they're compliant with your internal standards as well.
And now we'll go back to our questions. And actually, in the few minutes before we turn this over to our audience for questions, I did wonder, as I mentioned at the beginning, we purposely wanted to have 3 very different perspectives, the provider, the manufacturer, and the attorney. So what is something that you each wish the other knew? or maybe some other type of party in the health industry that you think, if people would just understand what we're dealing with, X could be so much better? What would you care to share? I'll start with you.
I guess on the device side of the equation, I think as technologies continue to evolve, I think what's really important is still having that eye towards how can we provide these devices with all the components that we've talked about here today, but also in a very cost-effective way. A lot of smaller community-based health systems, hospitals, clinics are challenged financially to be able to acquire the devices they may need to be able to offer some of these types of services. So this is where we really have to be open and thinking about the overall cost of the products that are being put into the marketplace. But then again, how can we leverage what the consumers are utilizing on a day in and day out basis? Now, it may not be clinically appropriate for all types of devices and all types of use cases, but I think having that eye towards the cost and not just trying to put out a slightly different variation of something that already exists as a whole. So that affordability, so smaller health systems can be in the game and not excluded from the game. I think from a regulatory and a legal perspective, we've been blessed with an incredible legal team and the compliance staff that we've hired within our center. They're part of the broader Mayo compliance and legal team, but they focused specifically in the digital space. And I think what we've learned by working more closely together is they have a much better understanding of the application of the technologies, what it means, and helping us think through the risk assessments for all of these various questions that come up in terms of interpreting the rules, but how do you interpret this? And also being just kind of mindful. They've been pivotal for us, though, working with government relations of how do we voice our views in terms of how the regs are out of date, and how do we help try to advance legislative changes to change the regs as a whole. And to me, I think that is a key opportunity for partnership in terms of helping to work with groups in terms of how do we make the voice heard that the regs are actually a barrier to helping patients, potentially doing it more cost effectively as a whole. And so I think there's a partnership opportunity there on the regulatory, legal, and compliance side.
Yeah, so from a manufacturer side, I feel like I have to answer the question on the device side. So part of the challenge from manufacturers is how the manufacturers today are regulated. Now it does serve the purpose to try to make everything safe, but it's very time consuming and it's extremely slow. So if you ask any medical device manufacturer to make a change of any decent kind, it generally takes them 6 months to a year before they can even get it out to one hospital. And this is, I think, that's one of the reasons for the cost that we talk about, as well as even though we were talking about remote monitoring and potential digital health, I think the whole landscape, the expectations in the digital space is that you're going to make, you have a security update. You get Apple sends you an update next week. You get an update in a week time or 2 weeks time, and that's where the expectations are going. Right. So there's got to be changes done from a regulatory perspective to look at the space to say, well, yes, it needs to be compliant, it needs to be safe, but what else can we do? Because I think if you have to wait for 6 months or a year to get an update to help something that your patients are relying on, I think that's unacceptable, and plus it adds cost as well. So I think that is one of the challenges that I think the industry is trying to figure out how best to solve, so that you can be timely, cost effective, but at the same time it gives you the flexibility to do what's necessary.
Yeah, I have no advice for the Mayo Clinic because I think they're in great shape here. No, I think in general, we've talked a little bit about getting physicians to buy into it, that they need to be willing to do the clicks, that they need to be willing to take the time and effort to learn the system and to use it with their patients. On the flip side, it's equally important that patients are involved and engaged as well. And that doesn't mean that this technology is for every patient. You have to make sure they have the right cognitive skills and physically able to do the work that's necessary or the tracking that's necessary in order to make the whole system work. And to that end, I think if manufacturers can just be focused on ease of use and making it as simple as possible to remove user error and to get people on board, the more successful these programs can be. That's easier said than done, of course, but I think the more we can remove the workload associated with this on either end, with physicians or with patients, the better the programs will be.
We'll open this up for questions. Anybody has one? Yes.
Yeah, would love to hear your viewpoint on, as we know, provider shortages are a big issue. They're very much concentrated to the urban areas, right? Especially when you talk about expertise, which you kind of touch upon with Mayo. Would love to hear your viewpoints on where we're going in the industry with remote monitoring, complex care coordination, expert second opinions. What is the regulatory and liability in that? I'd love to hear your viewpoints.
All right, I'll repeat the question. The gist of the question is, what is the future of remote patient monitoring, especially with respect to complex care coordination, regulatory perspective, and I think there was one extra.
Expert opinions, right?
And expert opinions. I'll open it up to the three of you.
You know, I think the continuation or the shortages of providers, and I think one thing, a compounding factor with that, it's the right providers in the right location. So rural America versus inner city, et cetera, is part of that whole equation as a whole. I will say, actually, one of the challenges we have when you factor that in is network access in rural America. So we were looking at South Central Minnesota, and we were amazed. We were not expecting this extreme, but the number of individuals that lived outside of their small community, which is many, could not get internet access. And so they were having to drive into the small community to be able to log on to access their medical record information via the portal. And so, one, we've got a bigger issue there that we still have to address as a society, is the infrastructure. I call it, it's basic utilities these days. It's like water, and we all need it to survive in today's environment. I think remote monitoring, again, can help us if it can help us to focus, keep the patients out of the clinic, do what we can with them locally. It's going back to the house calls in a new way. And being able to help manage them, I think we'll be better off. We'll have healthier patients in the end. We're also not bringing illness into facilities and really reserving that for the most sick individuals here. So I think there is going to be a place for it, but we do have to manage it. You know, the remote monitoring program that we're utilizing for post-hospital discharge, we now manage about, it's somewhere between 350 to 400 patients a day. So our average daily census in that program, and that's just from our community-based practices at this point in time throughout Minnesota, Wisconsin, and Iowa. So we actually follow strict protocols in terms of, okay, what are the criteria? We look at the EPIC risk score in terms of to really hone in on who are the patients that really can benefit from this type of service. Then working with the patient and the physician to say, we both agree to opt in, that this makes sense. There aren't social factors that would impede them being able to utilize this. So we really narrow that down. And it ends up being about 9% of the patients being discharged actually get enrolled into a program. They've been ruled out for a variety of reasons. Some of them are well enough, they really don't need it, so let's not force that upon those particular patients. So I think we have to be structured and apply it in the right use case, and it's not every patient in every situation. So I think, again, the design of the model, how it integrates with the rest of the care model is important. This is creating some challenges for some of the other care team models in the organization. It's like, hold it. Now we've got this whole remote monitoring solution, but we're just phone calling the patients. And so we've got a start of another study that will really look at, a redesign of the model, but how the benefit is really going to be in how do you bring these programs together. It's not one or the other, but how do you really tie them together? And I think that still that human intervention, that real-time education, dialogue with the patient is critical to the success of those types of programs. But narrowing down the use cases and the right patients is essential to be able to sustain this long term.
Yeah, and I would say that from an infrastructure standpoint, we're seeing a lot of this as IDNs are getting bigger, they're buying more hospitals, and what is happening is there's these small rural centers of clinics that they've bought, but they want to monitor them from their central location. So we're building infrastructure to be able to allow them to do that, and I think that trend's going to continue as the IDNs are going to continue to get bigger. But infrastructure is a challenge, like the network that you talked about. I know as an example in, I think, Lancaster, Pennsylvania, Penn Medicine paid to put fiber in the city because they thought it was more economically beneficial for them to actually pay to put fiber in the small play area rather than having those patients could drive over and get admitted to the hospital. So I think the hospitals themselves are also taking a different look at it and saying, why don't we just pay for building the fiber infrastructure in there so that'll allow us to do things like this. And I think as the small community hospitals go away, that trend's only going to continue.
I don't have much to add. I agree with everything they said. I think hopefully on the experts and specialists part that this technology will give opportunities for finding the exact right person you need to treat that person that would otherwise not have access to it from a rural community. On the malpractice liability side, there is a lot of tension if something happens and it was a quote unquote big city doctor treating the rural patient, that there's a lot of animosity and a lot of distrust there that will have to be developed over time. But otherwise, I think there's a lot of opportunity to improve healthcare in rural areas.
I think we have time for one more question potentially. That's a quick one. Or we'll bring it. Oh, yes.
Greg, you mentioned that the Mayo Uniform Data Platform was device agnostic, and you also mentioned that the devices may not be medical grade or could be consumer grade. Did you mean by that things like smart watches, fitness trackers? Like what types of devices were you referencing?
I'll repeat the question. I apologize just for those on the phone. A question for Greg around what was meant by the device agnostic practice.
Yeah, so the UDP is essentially the storage facility for all these data elements. There's another layer that we have worked with a vendor on in terms of the data aggregation. So from smart devices, whether it be a watch or whatever type of device, data being able to come in, be aggregated, then has the potential to be synthesized. But the actual data then is stored within the UDP. So the UDP is really a data warehouse. And I'll turn to the tech person here to correct me if I'm wrong on that. So I would view them as two different components that work together.
So could it be used for individual patient care or more aggregating trends and the like?
The question being if it could be used for individual care or for patient trends, and then we'll wrap up.
Yeah, so no, it can be utilized for individual care as well. So being able to pull, so we've got John Doe, we're looking at these data elements, those data elements being able to be pulled forward to be analyzed for that. A UDP concept, though, has merits in so many other facets. We use it for, data about our customers and others with a lot of other type of information, the continuing medical education program. So it's really a broader concept of data warehousing and then the aggregation from the other. But yes, individual as well as being able to do population-based analysis. So, and again, people sign off on data being stored as well.
I should note real quickly, in your packets, the materials for this session, there's included also an article that Harsh wrote and some links that Greg provided to additional clinical studies about the value of remote patient monitoring. So we wanted to be sure you had that as well during this time. and we'll be available during the break. We'll take a 10-minute break and re-adjourn at 10:50 Central, promptly for the next session. And of course, our panelists will also be around after all of the sessions during our mingling hours. Thank you, everyone, and thank you to our panelists.
Thank you.
Thank you.